Okay, we've got 25 people online, which is brilliant. Thanks for joining us this evening for the launch of the Healthcare AI community of BCS. My name's Jeremy Wyatt, and I'm the interim chair of this community. And we'll go on to discuss how we will be electing officers in due course. But we've put together a small committee to start with. I'm going to share some slides. I'd like to introduce you to the committee members who are on the call. Some people couldn't make it tonight, unfortunately. So I'll just bring up some slides and share those. Hopefully, that will come live. Is anybody seeing the slides?
Yes.
Okay, great. I will then maximize them. My machine's getting a bit slow at the moment. Come on. There we go. Right. I'll just go. So, as I said, I'm the interim chair. I'm an emeritus professor of digital healthcare from Southampton University and trained as a doctor a very long time ago. And I've been working in AI and healthcare since the mid-1980s, starting with a 3-month secondment to the Department of AI in Edinburgh University, as it was then, a long, long time ago. Anyway, moving on to the programme for tonight. First of all, really just welcome to you all, and I'd like the members of the interim steering group to introduce themselves. And then I will give I think I've got 4 slides, just exploring some of the aims and activities for this healthcare AI community. And there won't be time to discuss those right away because we've got this fantastic talk by Janak Gunatilleke, who's on our interim steering group, on where are we now with AI and healthcare. And that will start about 6:15. Lasts about 35 minutes, and we'll have a really interesting set of comments, I think, questions and answers on Janak's talk, and then we'll go back to questions and comments about the community aims and activities, and that would be easiest if you put your comments and questions in the chat, and then we'll close about 7 or soon after. So our interim steering group, you've heard about me. Janak, I know you're here. Do you want to introduce yourself?
Yeah, thanks, Jeremy. Hi, everyone. My name is Janak. I'm a director at KPMG, and I lead our health data and analytics practice there. Like Jeremy, I started working life as a doctor in the NHS and have spent the last kind of 19 years doing various other things within healthcare, including consulting and tech startup roles. And in 2017, I co-founded an AI consulting startup based in Sri Lanka, which is when I kind of really got interested in AI. And looking forward to talking to you in a bit.
Fantastic, thanks. Mercedes, are you with us this evening? Okay. Ed, are you joining us? I did have some apologies, and I apologize, I've lost count of them. Nick, are you around? I know you weren't at the Turing webinar earlier today, so perhaps not. Okay. Kieran? Janak, it looks like it's just me and you for tonight. Philip, are you here? No. Okay, well, that was a very quick round of introductions, and apologies that there's really just a couple of us turned out. And the other person from BCS who is on the call there is Jan Hugenwerth. Jan, do you want to introduce yourself? Explain your role with the BCS.
I'm Jan Hugenwerth. I'm the head of health and care at BCS, which means that I support all the people who are members of working in digital health and care roles.
Great, thanks very much, Jan. And Jan is a kind of go-to person for all the different communities within the health and care faculty. So if we can move on to the interim or draft aims and scope that the steering group has put together. First of all, we feel it's really important to promote better understanding and collaboration between healthcare and community professionals to realise the potential and the reality of AI and the NHS. And there are things like NHS data and record standards which I think are perhaps not so well known in some of the AI community. So that's one thing, and maybe some webinars on that. Then helping healthcare researchers, AI researchers, startups and developers to understand the opportunities and also the challenges of working in healthcare. And regulatory frameworks is obviously only one of them. There are many different challenges there. And we'll come back to that in a moment. Promoting a more evidence-based approach to the development, testing and adoption of high quality air in healthcare. And that's a phrase which some of you may be very familiar with, others may not, and that's something which is really quite important in the healthcare setting. And then finally, and this is perhaps a bit more speculative and probably a bit more resource intensive, we think it could be very useful to work with AI developers to really understand the barriers they face during development and implementation, the last mile problem, it may be a familiar phrase to you, and then bring together all the relevant partners, if possible, the regulators, the clinical professions, health services, commissioners, and AI developers in a kind of safe setting to discuss and explore these barriers, prioritize them, and how to harmonize the approaches to overcome those. And then that might lead to a kind of innovation pathway for healthcare AI in the UK. It would be fantastic if we do that. I think we'd want to involve some of the other organizations as well that are in this space. So that's perhaps a little bit more ambitious. And then finally, a note about the scope. AI is obviously used in a huge range of health-related areas, not just in, if you like, direct face-to-face patient care, but potentially management in health systems, but also for drug discovery and bioinformatics, which are really at another place, really. One wouldn't normally think of those as healthcare AI, and even in environmental and veterinary sciences, and this idea of one health, linking together human, environmental and veterinary health. So we need to discuss and agree which, if any of those areas, lie within the scope of our healthcare AI community and which will be looked at by others. And that's an important point, that we do have a very complex landscape for healthcare AI in the UK. Obviously, we are within the British Computer Society. There is the BCS Health and Care Faculty, which had its launch meeting back in October. And we are the BCS Healthcare AI community within that faculty. But there are other groups within that faculty. For example, I'm also part of the MCBK UK chapter, which I chair with Philip Scott, who chairs the BCS Health and Care faculty. And there are other communities, several other communities, which I don't know the names of, which may well have overlap and interest in the broader AI area. But outside of the BCS Health and Care faculty, still within the BCS, there's the very long established BCS AI Special Interest Group, which have been going for about 45 years and has a very successful annual conference in Cambridge, as you perhaps know, attracting hundreds of people. So there is a very strong AI community already within, broader AI community within the BCS. But outside the BCS, we've got a number of other organizations that we've already got good links with. There's something called FEDIP, which links directly with the health and care faculty. There's the Turing Institute and its clinical AI interest group, which, as I mentioned, we've already very much appreciate the links with that through Nick Fuggle, who's a member of our interim steering group. There's something called the Governance and AI Research Group, which I chair, and which we've already linked with the MCBK activities. It'd be nice to bring it together with the AI community. And there's at least one other organization focusing on AI in the UK outside of the BCS called the AISB, which again is very long established, been going for about 40 or 50 years, was based in the University of Sussex. And of course, there's lots of other organizations going beyond AI now. There's policymakers, patients, the public, healthcare professionals. There's Tech UK as an industry body, and the NHS, many organizations around the NHS. There's regulators of different kinds and educators as well. So apologies about the acronym salad here, but probably most of these acronyms are known to you. So we need to think about how we link in with any and all of these organizations, and what's our USP, what's our unique selling point, where do we want to position ourselves in this quite complex landscape. Well, I'll be interested in your thoughts and comments on that now. Perhaps you could put something in the chat and we'll return to that a bit later. And then finally, just a quick word about our current plans. We certainly want to set up a program of educational tutorial webinars, and we need volunteers for that. So please let us know again in the chat if it's something that you'd like to offer a webinar, an introductory or tutorial webinar. And we're going to be coordinating those with the Turing Clinical AI Group, which already has a very successful monthly webinar at lunch times. And as I said, there was just one today. We will be coordinating with them. We'd also like to have some more intensive, perhaps more technical workshops at probably at the BCS HQ that's meant to be in London. Maybe one in the first quarter and one in the third quarter of next year. And here are some suggested ideas. First of all, understanding and reducing barriers, as I mentioned earlier. There's a possibility we might be able to work with some ambulance service data sets. So that's an area where AI is obviously applicable, and I think is not, it's a bit of an AI desert, I understand it. So that might be interesting, almost a kind of hack day on ambulance service data sets, for example. And obviously, large language models are very topical. Something around the clinical use and potential risk and abuse of large language models could be another half-day or even one-day workshop. We need to hold an AGM sometime in the summer, I believe, with formal election of office, or at least by the early autumn, to be a properly constituted group. We also have the opportunity to contribute a session to the BCS Health and Care Faculty Conference, which I think will be in autumn next year. And finally, we've got the opportunity to contribute to the AI Special Interest Group, their annual conference in Cambridge. And they have a workshop session on day one, which we've previously contributed to, in fact, about a year ago. And we could have a longer term project. So these are specific events, but we could also mount a longer term project, almost like a research or policy analysis project. So I'll be really interested in your thoughts and suggestions about that, and ideas and volunteers for arranging any activities. So that, I think, is my last slide. I will stop sharing. And Janak, will you introduce yourself? And have you got your slides ready?
Yeah, sure, Jeremy. I think I've already done my intro, so
Yes, indeed.
I won't go again, but let me just share the slides.
Jeremy, there's a point in the Mark's made a point about the objectives.
Yes.
In chat, I don't know if you've seen it, about making one of the objectives perhaps being to ensure that patients, the public, are assured around AI.
Yes, no, that's a very good point. Thanks, Mark. Yeah, ensure patients are assured. Yep, no, that's very, very good indeed. Yes, and it might fit well with the BCS, broader BCS remit as well. Thank you for that, Mark. Great. Janak, you have the floor.
Yep, thanks, Jeremy. Just to check, can everybody see my screen and the slides?
Yep.
Perfect. All right, so today what I'm going to do is share some thoughts on the current status of AI in healthcare, including some of the latest developments in GenAI, what's working and what's not, both in healthcare and in other industries. Then I'll talk a little bit about where AI can improve patient outcomes and also non-clinical outcomes, and what we can all do better to support implementation and scaling of some of these AI solutions. I'll talk at a fairly broad level, and happy to sort of dive into specifics, answer questions, and get into more details during a Q&A session at the end. So before we get started, just kind of some definitions really. So people often ask me, like, what's AI? And there's a lot of definitions out there. And I prefer this really simple one, which is intelligent systems that mimic human thinking. So that's the kind of broad definition that I like for the kind of overarching umbrella that is AI. And within that, there's a few other kind of areas to quickly go through. First is machine learning, which is a subset of AI, which enables computers to learn through data and examples rather than being specifically programmed through instructions. And then within that, there's another subset, deep learning, which is actually draws inspiration from how things are built in the human brain, lots of neurons interconnected within a network. And what this allows us to do is do much more sophisticated analysis across large and more messy data sets. And the kind of last subset I want to highlight is generative AI, which is a subset of deep learning. And this enables us to create new content such as text, videos, music, and images. So generative AI is actually not new. It's been around for a while. OpenAI released the kind of GPT-3, which is the generative pre-trained transformer, back in 2020. And that consists of a large language model. But actually, generative AI started to kind of capture public imagination probably in 2021 with a tool that they developed called DALL-E, which enabled you to kind of provide it with some instructions as text, and then it used that instructions as a text and description to come up with an image. And then things really changed in November 2022 when OpenAI released a chatbot called ChatGPT, which is based on GPT 3.5. And that actually really changed everything in terms of capturing the public imagination and actually really pushing the boundaries and giving people a view of what could be possible and how it affects basically everything they do day to day, as well as some things they do at work. And this was evidenced by the kind of speed of adoption. So if you look at some of how fast certain technologies have been adopted, so things like Uber and Facebook, took more than 50, 70 months to get up to 100 users. Comparatively, ChatGPT only took 2 months to get to 100 million users. So it sort of was adapted super, super fast. And, generative AI has been generative AI has been kind of touted as having loads of use cases within healthcare. There's been some early successes that have been things like chatbots and generative solutions, acing medical exams, etc. We'll go into some of the use cases in a little bit more detail in a minute. But I wanted to also talk about some of the other kind of more technical kind of developments as well. So things like small language models, which are more specific models rather than the more generic large models, are also sort of becoming more and more important for more specialized tasks and sort of having better performance of certain things, and also being easier to run and more cost effective. The other big area is around the open source element as well. So there's a lot more sort of development in the more open space around some of these large language models compared to some of the more proprietary models that actually started the trend and the development. So both important in terms of the kind of innovation and the kind of ecosystem it opens up. One of the other kind of trends I want to talk a little bit about is decentralized training. We're kind of still fairly early on in this journey, but what this means is currently there's a lot of hardware requirements, and therefore a lot of investment required to kind of build the infrastructure and invest to actually train some of these models. But there are kind of good development or good sort of progress made towards looking at things like decentralized learning, which means that you can use a network of computers and kind of distributed infrastructure to actually train some of these models, which means that actually you can sort of get lots of people involved and kind of democratize the development of AI using large groups of people. So that's a really exciting space to watch. And another kind of more practical thing that we are seeing is kind of AI as a solution, which basically means that AI is kind of embedded into a lot of the solutions we see. So it's not like a AI solution per se, but it's a solution that has AI built into it. So Microsoft Copilot is a sort of almost a very good example. It's kind of embedded into things like Microsoft Excel, Word, etc. But also kind of a lot of the other systems and solutions now have some element of AI that they built in to enhance some of their previous functionality. So what are we sort of seeing more generally in healthcare in terms of the kind of backdrop and the drivers? So One thing is the kind of funding and sort of policy area. So in the spring budget earlier this year, the NHS is going to obviously has a lot of operational challenges, and it was expected, of course, challenged to deliver a 2% productivity improvement, and to sort of help with that, there was a £3.4 billion investment sort of announced in the spring budget, of which £1 billion was towards data initiatives, including pilots on how AI can improve some of the non-clinical use cases, which we'll talk about a bit later on. And this was kind of reiterated in the spending review in the autumn, where there's going to be more than 2 billion invested in NHS sort of tech and digital solutions to kind of run essential services. So the second element is around the Darcy review. So this was something that was commissioned back in July, and looking at the performance of the NHS and the challenges faced within it, and was actually published in September. Essentially, Lord Darcy's report found that the NHS was in critical condition in terms of the amount of people waiting on waiting lists, and the amount of access issues to GP appointments or NHS dentist appointments, all the time people were spending in A&E. And it was kind of, it was another area, kind of another instance where it was highlighted the kind of importance of technology, technology's role in sort of unlocking productivity and the kind of enormous potential of AI within it. This is also reinforced by Labour's manifesto in terms of thinking about NHS becoming more of a preventative service rather than a sickness service. So that's where sort of things like population health management and sort of advanced analytics associated with that become more and more important. And they've also explicitly called out the kind of technologies such as AI to be able to transform the kind of speed and accuracy of, for example, diagnostic services, and then the kind of impact that can have on patient outcomes. The other thing that's going on in the background is they're developing a new 10-year health plan. It's due to be published in the spring of 2025, and that'll sort of focus on three of the major Labour government shares, moving from analog to digital, from hospitals to communities, and from sickness to prevention. And as part of this plan development, there's been 11 working groups that's been established, and one of them is the Tech and Data group, and that's going to be sort of co-chaired by Ming Tang, who's the Chief Data Analytics Officer of NHS England, and Tim Ferris. So there's going to be a huge focus on sort of data and technology going forward, and some of the areas that they're expected to look at include AI, quantum, and genomics. So it's really exciting to see how that'll all shape up. Just wanted to give you a quick overview of sort of what the sort of sense in the market is and what people think about AI and specifically GenAI. So the dark boxes and blue boxes on the left was a survey KPMG did a little while ago, sort of more than 200 senior business leaders who were at companies that were quite large companies, more than kind of £1 billion in revenue, $1 billion in revenue. And this is some of the kind of insights that came up. So I won't read out the numbers, but there were some other numbers around sort of, AI was kind of shaping, 52% sort of said that it was shaping their competitive position, and it was 47% said that it was opening up new revenue opportunities for them. So it's quite a sort of a big focus for leaders in these kind of business organizations. And the dark purple boxes on the top, it was a survey we did in the US, about more than 1,000 people. And again, sort of the kind of general consensus, more than about 70%, felt that the benefits outweigh the risk. But on the flip side, almost half felt that there's not enough regulation to ensure that it was done safely. The kind of the blue boxes in the bottom right was a survey done by published in BMJ of about 1,000 GPs, and what that showed was about 20% of the GPs were using GenAI tools in their clinical practice, and almost 30% were using them to generate some documentation after they saw patients. And it was also, there's another study more recently done by the GMC and the Turing Institute about, again, surveying about just over 900 doctors about a year ago. And they looked at sort of the use of 3 types of AI systems: diagnostic and decision support, and then also things like that systems that have improved efficiency, and then also systems such as ChatGPT, where they're looking to create sort of text or images. Essentially, what they found is majority, so about 62%, felt that the generative AI systems that they were using improved their productivity. However, only about 15% felt that the training they received was sufficient. So there's some work to do there. So just to give you a bit of a flavor of what's happening across other industries. So you can see that AI and Gen AI has been kind of used in different forms. So BuzzFeed is a sort of online content creator, and they've integrated AI in terms of how they kind of create that content, and actually has got about 12% efficiency in terms of the effort they need to put into kind of creating that content. Unilever's used it to effectively target or more effectively target their ad campaigns, and that's resulted in like 50% cost reduction for them. Octopus Energy is another really good example where they've used GenAI to help their customer service agents, and that's going to result in them both in terms of kind of sort of efficiency, but also actually a 15% increase in the customer satisfaction of the people that actually receive that service, which is obviously also very, very important. So hopefully that gives you a bit of a flavor of sort of what's happening outside healthcare and where we're seeing the kind of good use of AI. So I like to put this up as a bit of a sort of a scene set, and almost as kind of a starting point for some of the kind of hype and potential of AI. So we know the co-founded Sun Microsystems back in 1982, and is now more active in the kind of venture capital space. And this is a statement that he made a little while ago, back in 2012, at a Health Innovation Summit in San Francisco, to a room full of doctors. So obviously a very controversial statement in terms of the impact that he thought AI was going to have. And I think he made it a bit tongue-in-cheek, but I think it's a good sort of sense check in terms of the hype and the kind of expectation of AI even back in 2012. So it's a good sort of a benchmark or a starting point to see, you know, this is what people expected, or some people thought AI might be able to do. So where are we now? I mean, I think the kind of real life applications of AI in healthcare has, you know, not been as impressive. And I think obviously AI is nowhere near replacing 80% of doctors, and that's not even the kind of right question that we should be asking, or the way we should be thinking about it. Just to give you a little bit of flavor of sort of the kind of almost the realities on the ground. So if you look at some of the academic publications, and there was a systematic review published a few years ago now, but things haven't changed that much. And they found that most of the, like 98% of the studies that they looked at were all retrospective, and mostly of the kind of very limited proof of concept approaches, rather than actually solutions that are widely scaled and implemented. And the other thing was a EU report that was published a couple of years ago now, and they kind of looked at the kind of the status of the development and adoption of AI in healthcare across their member states. And what they found was that there was a lot of interest and there was a lot of strategizing about it, but actually when they looked at the adoption, they found it was quite limited to specific departments and use cases. And the kind of number in the middle is also quite an interesting one. So this was a study published in MIT, done in conjunction with Turing Institute as well. So they looked at 647 solutions that were developed, AI solutions that were developed during COVID times to help with the management of COVID. And what they found is actually that, unfortunately, none of them were clinically fit for use, and that only 2 out of the 647 kind of deemed to be worth sort of further evaluation. So, there's a lot of hype and there's a lot of sort of expectation and weight of expectation on AI, but the reality on the ground is not always living up to that. So there is a lot of hype, and we talked about kind of some of the realities, but I do think there is actual potential for AI to have a good impact on patient outcomes and healthcare operations. So the way I kind of like to look at it is kind of think about 2 dimensions. The first dimension is kind of 4 boxes on the top, just looking at the patient journey from planning, prevention, delivery to management. And the second dimension is the thinking about the area within healthcare. So whether that's kind of a back office function, or whether it's a frontline function, or whether it's somewhere in between, kind of the middle office. And when you put those 2 dimensions together, you get like a grid, like what you see on screen. And then that just helps think about like the potential use cases in a little bit of a structured way. So, for example, you look at the cross section between prevention and the kind of back office. You get opportunities around population health management, and then when you look at the cross section between delivery and kind of that middle office, you can look at things where AI can help with and delivery of kind of medical and surgical procedures. So, for example, there are AI solutions that help during endoscopies, where you put a camera down a person's throat to look at the sort of the gut, and AI solutions can help the clinician operating that endoscope in real time to say, okay, these are potentially some abnormal lesions, so you should probably have a look at that. So it's things like that. So just to give you another example, is there's a lot of kind of maturity or increasing maturity in the electronic patient records that are deployed at NHS organizations, which means that there's going to be a lot more kind of structured information as well as much more digitized information going forward. So that gives opportunities to look at how you can use that information and use AI to help clinicians with kind of decision making around the drugs they prescribe or some of the other treatments they give to kind of reduce or minimize the errors that might happen otherwise. So because we've talked a lot about AI, generative AI, I thought it'd be good to talk a little bit about sort of some of the specific use cases when it comes to GenAI. So when I think about GenAI, I like to think about it across these 5 categories. So for example, if you think about content generation, that could be around helping draft a discharge summary, or generating compliance or regulatory documents in the life sciences setting, or just drafting patient letters. In terms of information extractors, we are seeing that used to kind of analyze large amounts of clinical notes and documentation, and to be able to actually extract some of that elements to automate some things like, for example, clinical coding, or to actually look at sort of common symptoms or common treatment patterns across patients to say, well, this is a cohort that might be suitable for a new clinical trial or a new treatment, etc. Smart chatbots are seeing a lot of that being used and thought about for instances where it can be helping departments like HR or finance, where they can help the staff access and self-serve, so that the staff in the HR or the finance departments can actually spend their time doing more high-value tasks. Code generators is also an actually interesting one. GitHub recently announced a solution called Spark, which allows you to actually explain in sort of plain English without writing a single line of code what you would want, and then the actual Spark comes up with develops kind of a web app on your behalf. So what that does is kind of opens up lots of opportunities for people that don't necessarily have that coding background, but have ideas and want to develop at least initial solutions and to sort of test out in different scenarios. So there's kind of loads of different applications within generative AI. So just to kind of set the scene a little bit on the non-clinical side as well. So I think until recently, there's been a lot more attention on clinical AI because I think it's kind of deemed to be more interesting and potentially more impactful. However, clinical AI is more complicated, right? Because there's a lot more sort of regulatory and compliance and ethical issues as well. And it's kind of the burden of kind of accuracy and explainability is also extremely high. So with all of that in mind, I think we're seeing a lot more of a shift to kind of people looking at sort of some of the non-clinical areas. So if you kind of look at the healthcare sort of operations in general, you kind of have the corporate services, kind of the back office, the operations, the kind of middle layer, and the clinical services. So more and more what I call the non-clinical, which is kind of the combination of the kind of operations and corporate services areas. So based on that kind of non-clinical areas, we did some work earlier this year to identify some what we think are the kind of top use cases in that sort of non-clinical area, and we kind of ranked them based on the amount of impact that it might have and the kind of ease of implementation. So what you see in that kind of top right-hand corner is the result of that work. So just to give you a flavor, a couple of them, so it could be like, imagine during a consultation, your clinician can spend their entire time interacting directly with the patient. They don't need to worry about entering their notes into an EPR or anything like that, which kind of enables you to have a much more sort of meaningful patient-clinician relationship and also sort of spend more time with them. So that's one example. The other example I just want to pull out is like clinical appointments. So this is about sort of saying, well, okay, how can we use AI to schedule them more intelligently, taking into account patient preferences, patient demographics, are they working, therefore, what time is going to be more suitable for them, simple things like that, as well as combining that with more personalized communications around when those sort of appointments are communicated to them. The idea being all of that is to improve the attendance. So there's a few trials going on looking at how that can actually help reduce the do not attend rates or did not attend rates for hospital appointments and clinic appointments, so which is a big issue. So just to give you a quick overview of some of the kind of real life examples of where we see kind of AI being implemented. Radiology is an area where there's a kind of high number of solutions, and that's because it's kind of more as a kind of a specialty. It's been digitized for a little while with their PACS and risk systems, and also because of that, they've got a workforce that are kind of more comfortable with using digital solutions. So Brainomix is a good example. It uses machine learning techniques to kind of review the CT scans of patients' brain to identify and quantify damage, potential damage during or blockages during a stroke. What that allows us to do is like quickly identify what sort of treatment that patient might need. It's now implemented about 2/3 of the stroke units in England, which is really good, and it's kind of improving both the turnaround times and the kind of patient outcomes, which i.e. the kind of in the amount of patients that are independent after a stroke, which is really good. So the other kind of examples in the kind of other clinical areas include things like skin analytics, which is kind of helping identify kind of skin lesions in dermatology, or vice in mental health, and that helps deliver cognitive behavioral therapy using a chatbot. In the non-clinical areas, there are examples such as Doctor, who have a risk stratification tool, which is identifying the patients that are most likely to miss that hospital appointment, and again helps do more targeted interventions to that. So just to give you a bit of a sense of like some of the challenges to deploying AI in healthcare. So while AI has been kind of successfully deployed at scale in other industries by companies that are kind of household names, right, like Amazon or Netflix and Uber, when it comes to health, the stakes are a lot higher. and it becomes more personal, right? Because it's sort of your family, or it's an actual individual that you're talking about. So the challenges, I like to kind of identify them across three categories: people, systems, by which I mean the kind of environment into which that solution is deployed, and technology itself. So within the people category, users need to trust and have confidence in the output of these solutions. They need to have the knowledge to be able to actually make informed buying and use decisions. And a lot of frontline staff are very, very stretched, so they don't necessarily have the headspace and protected time to engage with the development and support implementation of these solutions. From a system perspective, I think one of the biggest things is around integration into kind of established clinical pathways and processes that have been around for like 15, 20 years. And also the regulatory requirements and some of the funding and procurement processes that people have to navigate to get these solutions out into kind of real use. And from a technology perspective, access to data and kind of, even when you access that data, the quality of that data and overcoming things like bias, etc., is really, really tricky, because data is spread across multiple systems, fragmented systems, and different formats, etc., etc. So it's quite very hard to sort of bring all of that together. Just to point out very quickly a couple of risks. So we talked about some of the challenges, and these are kind of some of the risks that we need to think about specifically when we look at GenAI, and they're kind of new in that sense. So I guess a couple of things. One is around, ChatGPT can be very good at coming up with answers and being very confident when they come up with an answer, but that doesn't mean that it's always right. So we need to always think about that sort of risk of sort of inaccurate information or hallucinations. And the other thing is around privacy, kind of thinking about what information we should be sharing with some of these solutions, especially these publicly available solutions like ChatGPT, where that data can be then used to train their models and be shared for other things as well. So those are some of the kind of new and additional things to consider when we're looking at GenAI solutions. Something else that is quite interesting is thinking about the sort of interaction between sort of humans and AI systems. So one good example is, there's a study done looking at sort of prescribing for antidepressants, and the AI solution, even when it made a sort of incorrect suggestion, if that was actually accompanied by a sort of a reasonable sounding explanation, it actually adversely affected the behavior of the clinician. So that's really something important to think about. Efficiency is another sort of a big area. Does it actually improve efficiency? So that's something, there's been some early studies thinking about, okay, it theoretically should improve efficiency, and does that in a test environment, but when it's actually released into a real life environment, it kind of, depending on how it actually impacts the clinician's behavior and whether they actually do any extra checks, etc., and how they perceive it, actually means that in some cases, for example, there was a study done on prostate MRI reading an AI solution. It found that it didn't actually reduce the time overall. So these kind of things to consider. So how do we improve kind of adoption scaling? So I have kind of three things to say, kind of share on this. The first thing is very basic, right? So just kind of, we need to solve a real problem, and it's kind of very kind of obvious thing to say, but what I often see is people getting really, really excited about like a really clever technology, and then sort of almost trying to shoehorn that back into a problem. Like it's almost like a solution looking for a problem. And we need to kind of start with the problem. And these days, where there's loads of problems, that problem needs to be important enough that somebody's going to actually give you the attention and resources to actually go and solve it. The second thing is thinking about the kind of life cycle and who you are as a stakeholder, right? So in the top, you have the kind of life cycle of AI solution development, from identifying it to designing it to deploying and monitoring it, and then the stakeholders on the left, whether you're a developer or an end user like a clinician or a regulator. So again, put those two things together, you get a grid which sort of points out some things that would be helpful to do during those different stages. So for example, in the design phase, the innovator needs to really work on their value proposition to make sure they're solving the right problem and that solution they've got actually addresses that problem. In the develop phase, you kind of need to think about some of the enterprise standards, because you're in a clinical environment or hospital environment, and think about how you're going to capture some of the evidence as well. And if you're a sort of a manager or an operator, you need to think about sort of allocating enough resources to support that implementation. So for example, to gather test data or to gather benefits and free up some of that frontline staff time as well. The third thing to think about are what I call enablers, and those are kind of across these 5 areas: data, collaboration, sustainability, etc. So for example, we've talked about how data can be a challenge. So having access to good data and having access to good data on a regular basis is really, really key to success. And again, we talked about sort of the fragmented systems as well. So like there are things that need to happen from standards perspective and having APIs, etc., to be able to have those data shared across those systems. And finally, the people that actually going to help and engage in these projects, they need to have the right skills and have the right competence to be able to engage in a meaningful way. So that's another important thing to consider as well. So just to kind of finish off, it's kind of 3 practical elements especially when it comes to sort of non-clinical AI solutions that we find that's really, really important to keep in mind. The first is the kind of the integration into the workflow, right? Even for non-clinical solutions, you need to consider like, what's the existing process? How does your solution impact that? And make sure that it doesn't impact in a sort of an adverse way that's going to actually counteract the positive effects of your solution. And identifying and tracking benefits is really, really important, because a lot of the time the business case for your solution is going to be dependent on the outcomes that you're going to deliver. So thinking about how you practically and effectively baseline performance, and then how you kind of track and kind of demonstrate benefits is going to be really, really important as well. So there's a third element is we talked a lot about sort of the kind of risks and the kind of governance. So the trusted AI approach is something that we use when we work with clients, and that's kind of a kind of an approach where it's kind of has 10 elements, and that's a kind of a comprehensive way to think about the risks and sort of governance that you need to have in place when you're kind of identifying AI solutions, developing them, and then also deploying and sort of managing them in the long term. So I think very quickly, how does that work in practice? So kind of if you think of from an end-to-end perspective, kind of starting with your AI strategy, making sure that's kind of actually aligned to your organization objectives or the big problems that you have, thinking about like what do you have in the sort of current state from a governance and process perspective, and then what are the gaps, putting those into place, thinking about the risk appetite. That's really important as well. Different organizations have different risk appetites, and then developing those policies and processes and kind of getting them up and running. And that sets up the foundation for you to actually then safely experiment, safely do proof of concepts, and then safely scale those that actually are successful. So just to leave you with a final couple of thoughts. So, AI, I believe, can improve healthcare operations and patient outcomes. And I think there is an increase, and I think there'll be continue to increase focus on the kind of back and middle office, so the sort of non-clinical aspects. And I think for success, we need to have a strategic approach. So not think just about the technology. We need to make sure we're solving a problem. We need to think about the patients, and we need to think about some of the enablers and where you are in that solution lifecycle. So I hope that's been useful as an overview, and I'll hand back to Jeremy to manage questions.
Many thanks, Janet. That was fantastic. Do you want to stop sharing there? There's a great overview and very brief, but lots of material in that. And I think that, are you happy to share your slides? I think we have been recording this session, so it will be on the BCS YouTube channel. If people want to go back through and slowly and rerun your talks, there's a lot of material in there. We've had a number of really interesting, provocative questions. Jennifer and Aaron were commenting about the poor quality of data. Is the quality of data in the NHS too poor to support accurate and useful machine learning?
Yeah, I mean that's a good question. I think that's often a challenge, and I think there's been a lot of work done more recently, and there's sort of national initiatives as well, looking at how we can sort of standardize data across sort of organizations, etc. And I think one of the other things as well with newer kind of technologies like GenAI, some of that training is already done for you. So in that sense, you're not as dependent on that sort of source data for your training. But for traditional models, yes, absolutely, we need to consider like whether you have good enough data, and also good enough data on a consistent basis. So there's no kind of easy answer for that. But I think what we find practically is that when we're looking at a solution, it's really important to assess like the quality of the data upfront, and also whether you can continually get access to good quality data, because we've been in instances where like it's taken 6 months to get that first lot of data, which is great, but then when you actually implement it, or you need it every week, and that just doesn't work. So there's some practical considerations on that side.
And we haven't mentioned the need for representativeness, particularly of smaller communities and so on, to avoid algorithmic bias. So yes, that's great. Thanks. Marlene made the point that people with long-term conditions spend 99% of their time by themselves, away from the health system, but nevertheless responsible for about 80% of the cost of the NHS. Is there a role for AI to support those people, self-caring?
Yeah, absolutely. And I think that's where, especially with some of the kind of GenAI kind of conversational agents as well, I think there's some interesting work around, how we can almost act as a coach, and help sort of uh, provide more sort of continual input. As Mike correctly pointed out, they spend a lot of time kind of managing their condition by themselves. So there's opportunities to kind of help them through that process, both from sort of a coaching perspective, but also if they have any questions, etc. So there's a few areas that different providers are or sort of solutions and startups are exploring in that space for sure.
Thanks. Yes, and Chris and Jennifer were keen that patients should be involved in prioritizing which use cases to explore. So the idea of co-production, and Susan Levy also mentioned this, not only developing algorithms, but also in developing policies and safeguards. So is that something which you've seen happening? Is that growing, the idea of co-production with patients?
Yeah, I think yes. So I think certainly when we did some work, for example, with where some funding was provided from sort of a central sort of NHS body, what some of the criteria they were looking at was sort of patient involvement in terms of solution development, also look at some of the kind of risk element as well. And so I think it's recognized as an important thing. Does it happen all the time? Not necessarily, but I think there is definitely sort of recognition of the importance of that, and the more mature organizations definitely I've seen do that.
Thanks, Janet. You're absolutely right that the NIHR insists not only on patients and the public being involved, but that they should be involved in an ongoing way. So real genuine co-production, not just consultation at the beginning and dissemination at the end. And that you should reserve a portion of your budget, your grant budget, for that. So NIHR has been very much a leader in that. It has an organization called Involve to support patient engagement. Susan Levy also asked about the role of AI in education of aspiring professionals so that they can practice safely once qualified, which struck me as an interesting idea. You want to comment on that? Just a great idea.
Yeah.
And
Definitely.
and in the Q&A, well done, Oluwaseun, sorry, I probably haven't pronounced your name correctly, but you make a very interesting point about there is discussion about entrepreneurs running healthcare in the future, not healthcare professionals. Janak, is that an idea that you've heard of? Can you point to any case studies or examples of organizations that are already treading that path?
Yeah, I think I think it was on the slide I put as well up that quote from that talks about sort of healthcare being influenced and sort of shaped by outsiders. I think there's a lot of good sort of ideas that come from outside healthcare and from people that are patients, for example, or some of their family members might have gone through a particular challenge and they see that firsthand and they come up with a good idea. But I just firmly believe in the sort of co-production element. They might have that idea, but I think when it comes to actually developing that out and building something and making that successful, you need to involve clinicians, you need to involve the patients and all appropriate parties. So I think ideas might come from outside, and we should encourage that. But I think when it comes to developing them, that needs that sort of multidisciplinary approach.
Great, thank you. Unless there's any other burning questions, I think we should perhaps go back. Many thanks indeed, Janet. That's been a great overview. As I said, you compressed a lot in. I do recommend that people re-watch your talk on the YouTube channel because I've heard your talk before, but I heard new things this time. I think you've also added to it and updated it, so it's great. Could we perhaps go back to that challenge that I set people right at the beginning, really talking about the objectives, and what I could do is perhaps just put up my slide of the objectives. I think that's perhaps the most important thing, to just really try and get our objectives clear for the right. Yes, this is not quite right slide, but I'll just go back to the objectives here and just get rid of all the screen junk there. There we go. Yes. So we've got promoting better understanding between healthcare and computing professions, and for example, sharing insights around NHS data and record standards. Helping researchers, startups, developers to understand the challenges and opportunities, including relevant regulatory frameworks, which is kind of linked to the first objective. Promoting a more evidence-based approach to development, testing, and adoption, and evaluation isn't, well, that's part of testing, but a wider range of evaluation studies that could be done. And then the final one was really trying to understand with AI developers what kind of barriers they're facing, not only during development, but also during implementation, and they're helping overcome some of those barriers or reduce some of those barriers, and even developing a kind of innovation pathway for healthcare AI by bringing together all the relevant parties. And I'd be interested to know what people feel about that. Perhaps you could put something in the chat if you've got any. Are there any aims there that we don't want? Are there any new and different aims that we should be exploring? Are those aims already covered by some of the many organizations? And just to remind you about all those organizations, we've got lots of organizations around the BCS, outside of the BCS, but in the kind of still in the AI or health informatics space. And then there are also organizations which are highly relevant, including patients in the public, NHS trusts, regulators, educators, Tech UK, and policymakers, etc. So if you've got some thoughts about that, I can't see the chat at the moment. I'm just coming back. And yes, Susan, you say that the aims are not inclusive. Healthcare is not just about NHS. And what about care? Yes. So I think that's a very good point, and that's something which we'll take away. And thanks for that comment. Public understanding was something which was the point which was made earlier. I haven't adjusted the slide in between the first presentation of it, but yes, involving and assuring patients about the role of AI, and it was Mark, I think, initially made that point, but Marlene, you rightly say that this is something which we could and should be doing, especially with the BCS, which I think has a strong history and track record of working with the public, trying to enhance public and general understanding of what the potential and the reality of information technology and computer sciences. So that's great. Thank you. Yes, healthcare is not just the NHS. That's a good point. And certainly care, AI in care services, so social care, I think you probably mean there, Susan. Anybody who'd like to, Susan, do you want to unmute and explain that comment about the aims not being inclusive? I hope you can unmute your audio and let us know what's the thought behind that. Okay, you're just shy. Maybe your audio video is not working at the moment. But it's good to have had your comment anyway in the chat. Is there anybody else who's got a burning comment? I see that we're kind of at time now. Susan, is that you coming? Ask to unmute. I can do that. I don't know how that works. There's a little button come up. Okay. Any other? Susan, is that you?
It's not Susan. Susan is my wife. I'm using her computer.
Right.
Okay,
What's your name?
My name is Sharon Levy.
Right.
And I think the issue around inclusiveness is important because it's not just about other home countries like Wales and Scotland, where I'm based. It's also about the use of the word patients, which is very health centric, and we need to move away from that. The other thing I wanted to say is about the EDI inclusiveness, the issue that AI is very much looking at the male, white, middle age, and we need to be aware of that and think about contingency or strategies to ensure that whatever we develop is really addressing the minority group. You talked about communities, Jeremy. I think minorities are important element. And finally, I want to say that children and young people are really an important segments that are often undervalued or not being considered when you talk about patients' involvement or public involvement because they don't vote, yet they have really important insights about the future. That's it. Thank you.
Fantastic, thanks. And I think you also made the point about AI and in the education of aspiring professionals to help them practice safely.
Correct. So I work in Edinburgh University, and we are preparing professionals, both medics and nurses, that I'm not sure can actually, at the end of the 4 years or the 5 years or the 7 years, are ready to work in the future of healthcare that is really based or heavily relying on machine learning, and we really need to embed that in undergraduate curriculum as a starting point. The postgraduate people in practice, we can manage that quite effectively, but it's the mindset of embedding that in undergraduate professional development, professional education.
Fantastic, thanks. I wrote a piece about 20 years ago about the need to prepare nursing, therapy, and medical students for a world in which they might be practicing some of their time in what I called then distance medicine, so telemedicine, virtual consultations, and so on.
Is that when you were in Dundee?
Yes, and needless to say, nobody took it in. The traditional response being, Jeremy, great idea, but there's no time in the curriculum to fit that in. Well, it doesn't need to be time in the curriculum, it just needs to be demonstrated and to be part of the practice that they are seeing. So really interesting, Siobhan. Thank you very much indeed for those comments. Anybody else? I think we're going to have to wind up quite soon, I'm afraid. This has been a fantastic session, and many thanks indeed again to Janak and to all of you for your comments. It is being recorded, so I hope you'll be able to rerun it. I think I gave my email address, Southampton, in the chat. So if anybody wants to wind back and check that and contact me with some comments, questions, if you'd like to volunteer to run a webinar, there's lots of interesting ideas that I think would make really quite provocative and interesting webinars for this community. Any other ideas you've got about what we can do as part of this fledgling health care AI community, we'd be really interested and delighted to hear from you. So unless anybody has got any other comments or questions urgently, I think we probably better wind it up now. Technically it's 7:05. We've had a fantastic turnout, and we will be back in touch with you with news of our next activities in due course. Meanwhile, everyone enjoy the festive season that's coming. So thank you very much indeed, and lots of claps and thumbs up I see floating around the screen. So thank you all for your engagement. And there's another new message there before I close. Yes, an effective system. Marlene says there needs to be an effective system quickly and effectively regulating AI. Yeah, it's a register of approved tools. Yes, I agree. And actually, each system or algorithm needs to have its separate identifier as well. And I'll just leave you with this thought, which came from the Turing clinical AI session today, that until there is a separate identifier for algorithms, the algorithm developers won't get payment for them in systems where payment happens. And equally, it raises medico-legal questions. So exactly which algorithm and which version of which algorithm was used in that clinical consultation, which led to mishap. So yeah, just having that issue of unique identifiers would be really important. So thank you, everyone, and sorry to draw it to a close, but I think we've probably all got homes to go to and suppers to have. So thank you, everybody, and look forward to your engagement in our future sessions. Bye.